Welcome back to the deep dive. When you start trying to wrap your head around conditions like bipolar disorder, major depression, substance use disorder, or even thinking about really critical safety things like suicide risk or how to manage aggression, it can honestly feel a bit overwhelming, like you're staring at this huge, complex map. Where do you even start?
Oh, absolutely. It's true. These areas, mental health, substance use, they involve some incredibly complex stuff, right? Biological processes, really personal struggles. And then there's this whole range of ways we try to help people navigate it all. Yeah, making sense of it definitely needs a clear guide of focus.
And that's pretty much exactly what we're setting out to do for you today. We've got this pile of sources, documents that really dig deep into these specific areas. Our goal isn't just to give you a summary. It's more like we want to unpack these documents with you, pull out the most vital bits of information, help you understand the core features, the risks the sources talk about, how these conditions are treated, and importantly, the safety considerations they highlight.
Right. Think of it like a guided tour, maybe, through some pretty crucial mental health and substance use territory, but based entirely and only on the material we were given.
Exactly. We'll be extracting those key details, maybe some surprising facts, and definitely the essential warnings, all coming directly from these documents, focusing on what the sources tell us is most important for you to understand these topics.
Okay, let's get into it.
All right, let's dive into this stack. So the sources seem to start by mapping out mood disorders first, right? Giving us descriptions of bipolar disorder and major depressive disorder. They really seem to focus on the different ways someone's mood can be, well, profoundly affected.
Yeah, that's right. And when the sources talk about mood disorders, bipolar disorder often comes up first. It's, known for those dramatic shifts in mood. But the sources, they define it carefully through distinct types of episodes. They break it down into three main types.
Okay, what's the first one?
First is bipolar I. The sources say this is defined by having at least one full-blown manic episode.
Full-blown manic,
Yeah.
meaning?
Meaning it has to last for a week or more, according to the sources. And it causes these really significant changes in behavior, energy, thinking. Now, depressive episodes often happen at bipolar 1, but the sources are clear they aren't actually required for the bipolar I diagnosis itself. The mania is the key.
Okay. But there was a critical warning linked to bipolar I in the sources, wasn't there? Something concerning.
Yes, absolutely.
Yeah.
A crucial point flagged directly in the material. Bipolar wide is associated with the highest suicide risk among the bipolar types discussed in these sources. That's a really sobering point they make.
Wow. Okay. That link between the severe mania and the high suicide risk is definitely something to keep in mind. So what's the next type?
Then there's bipolar 2. According to the sources we have, this requires experiencing at least one hypomanic episode.
Hypomanic, so less severe than full mania.
Exactly, a less severe upstate. And it also requires at least one major depressive episode. The defining difference from bipolar 1, as the sources really emphasize, is the total absence of any full manic episode. No full mania, ever.
So the highs in bipolar 2, they aren't as extreme or debilitating as in bipolar 1.
Precisely. The sources describe them as representing a noticeable change, sure, something others might observe, but not the severe impairment you see in full mania.
Right. And that leads to the third type.
Cyclothymic disorder. The sources describe this one as more of a chronic, fluctuating mood state. It needs to last for at least 2 years in adults or 1 year in kids and teens. It involves periods where someone has hypomanic symptoms, so not a full episode, and periods with depressive symptoms, again, not meeting the criteria for a full major depressive episode.
So like a milder but more constant up and down cycling pattern.
That's a good way to put it, yeah. A milder, more chronic cycling.
The sources seem to really focus on nailing down the differences between mania and hypomania. Why is that distinction so important, according to them?
Well, the sources emphasize it's vital because it really comes down to the severity, the impact on someone's daily life, and frankly, safety. They give the specific criteria to differentiate them.
Like what?
Okay, so duration is one key difference. Mania, the sources say, has to last at least one full week. Hypomania, on the other hand, is defined by lasting at least 4 consecutive days.
A week versus 4 days. Okay. What else?
Functioning, this is maybe the biggest one. Mania, the sources state clearly, involves severe impairment. Often it's so significant that hospitalization is required, to ensure safety and stability.
Right.
Hypomania, however, involves an observable change in functioning. Maybe friends or family notice something's different, but it's specifically not severe enough to cause that marked impairment in work or social life, or to necessitate hospitalization.
So someone in a hypomanic state Maybe they're super energetic, incredibly productive, perhaps talking more or being a bit impulsive, but they can generally still handle their job, their responsibilities.
That's the idea. Yeah.
Whereas someone in full mania might be completely unable to work, maybe making really poor decisions, possibly even struggling with basic self-care.
That's exactly the kind of difference and impact the sources describe. And there's another key factor they mention, psychosis.
Psychosis, like hallucinations or delusions.
Right. Psychotic features may be present in a full manic episode, but the sources explicitly note that they are absent in hypomania.
And that brings us back to hospitalization then, often needed for mania because of the severe impairment or maybe the psychosis,
Right.
but typically not required for hypomania.
Okay, understanding that distinction definitely helps clarify the spectrum of up moods in bipolar disorder as the sources present it.
It really does. Now, the sources also give us some data on who is affected, some epidemiology.
Okay, what do they say?
They talk about lifetime prevalence. That just means the percentage of people likely to experience the condition at some point in their lives. For bipolar 1, the estimate from the sources is somewhere between 1% and 2.6%.
And bipolar 2.
For bipolar 2, it's lower, around 0.5%, according to the material.
And when do these conditions usually start? Is there a typical age? The sources note the average onset tends to be late adolescence or early adulthood. For bipolar I specifically, they often mention the window of 18 to 30 years old. And there's an interesting point the sources highlight about gender.
Oh, yeah.
Bipolar I seems to affect males and females roughly equally. But bipolar 2, the sources say, is more common in females. They don't really speculate on why in the material we have, but they do note the difference.
Interesting. Any other demographic notes?
They mention higher rates seem to be reported in high-income countries. Again, no reason given in the source, just the observation.
And we need to circle back to that critical safety point, the suicide risk.
Absolutely. The sources reiterate this. They state the risk of suicide in people with bipolar disorder is about 15 times higher than in the general population. That's a staggering number.
15 times.
And, as we mentioned, they specifically link the highest risk within that group to bipolar I. It's a point the sources clearly want to drive home.
Definitely. So why does bipolar disorder happen? What do the sources say about risk factors?
They outline several categories. Biological factors are definitely a big piece. And there's an interesting side note in the sources associating bipolar, like sometimes with a high IQ, and that typical 1830 onset.
Okay, what kind of biological factors?
Well, genetics plays a significant role. Having a first-degree relative like a parent or sibling with the disorder substantially increases someone's risk, according to the sources. Neurochemical factors are also key. The sources talk about dysregulation, like an imbalance, in important neurotransmitters, specifically dopamine, serotonin, and norepinephrine. These chemicals are crucial for regulating mood, motivation, energy levels.
Makes sense.
And the sources also point to structural differences in the brain itself. They mention potential abnormalities in areas like the prefrontal cortex that's involved in decision-making, impulse control, and the amygdala, which is central to processing emotions.
So a definite biological component. What about environmental factors? How do they fit in?
The sources list several. Things like experiencing trauma or abuse, significant disruptions to sleep patterns, substance use.
Substance use again.
Yes, it comes up frequently. Also, major life changes or periods of high stress. The understanding presented in the sources seems to be that these environmental triggers can interact with an underlying biological vulnerability, potentially leading to the onset of the illness.
So nature and nurture interacting, essentially.
That seems to be the picture, yes. And they also mentioned cognitive or behavioral factors.
Such as?
Things like impaired executive functioning, difficulties with planning, organizing, problem solving. Also, poor impulse control and having a low frustration tolerance.
You can see how those could contribute, right? Like poor impulse control during a manic phase could lead directly to risky behaviors, the sources describe.
Exactly. It fits together. And one more thing the sources emphasize is comorbidities.
Comorbidities, meaning other conditions that often show up alongside bipolar.
Precisely. Comorbid just means occurring together. And the big one the sources highlight for bipolar disorder is anxiety disorder. They state it's present in a whopping 75% of cases.
75%, that's huge.
It is. It highlights how common it is for mental health conditions to overlap, and having both bipolar and anxiety can certainly make diagnosis and treatment more complicated as you're trying to address multiple sets of symptoms.
Okay, that gives us a pretty solid picture of bipolar disorder. The types, the characteristics, the risks based on these sources. Now let's shift gears a bit to depressive disorders. While bipolar has those characteristic ups, the sources seem to define depression primarily by that persistent low mood or maybe a loss of pleasure.
That's the core of it, yes. The main focus in the material provided is on major depressive disorder, or MDD. The sources lay out the specific diagnostic criteria.
Which are?
You need to experience 5 or more specific symptoms within the same 2-week period. And critically, one of those symptoms must be either a persistently depressed mood or what they call anhedonia.
Anhedonia, that's the loss of pleasure, right?
Exactly. The inability to find enjoyment in activities that you used to find pleasurable. It ties back to those reward pathways we might discuss later. Disruptions there can really manifest as this lack of enjoyment.
Okay, so depressed mood or anhedonia is required. What are some of the other 5+ symptoms the sources list for MDD?
They include significant changes in weight or appetite, either increases or decreases. Sleep disturbances are common, sleeping way too much, hypersomnia, or way too little, insomnia. Also, significant fatigue, or what they call anergia, that profound lack of energy. Feelings of worthlessness or excessive guilt, difficulty concentrating, thinking clearly, or making decisions, recurrent thoughts of death or suicidal ideation, and finally, psychomotor changes.
Psychomotor changes, what does that mean?
It refers to observable changes in movement, either being noticeably slowed down in speech and movement, that's psychomotor retardation, or being physically agitated, restless, unable to sit still, psychomotor agitation.
Wow. You can really see how a cluster of those symptoms like the fatigue, the impaired concentration, the anhedonia would just make daily life incredibly difficult.
Absolutely. Severe impact on functioning.
So what about the risk factors for MDD? Do the sources say they're similar to bipolar?
There's definitely some overlap, but also some distinctions noted in the sources. Biologically, they mention genetics. Again, family history increases risk. And neurochemical imbalances, particularly involving serotonin and norepinephrine, similar to bipolar. On the psychosocial side, they highlight ACEs, adverse childhood experiences.
ACEs. What does that encompass based on the sources?
The sources use it to refer to potentially traumatic experiences during childhood. Things like abuse, neglect, or growing up in a household with significant dysfunction like substance abuse or domestic violence. Other life stressors and having other medical or psychiatric comorbidities are also listed as risk factors.
Are there specific demographic groups the sources mention being at higher risk for MDD?
Yes, the sources note that MDD is more common in females and also in older adults. And again, having first-degree relatives with MDD increases the risk. And here's an interesting personality factor the sources specifically call out.
What's that?
They highlight neuroticism as a personality trait that functions as a risk factor for developing MDD.
Neuroticism, like a tendency towards anxiety and worry.
Generally, yes. A tendency towards experiencing negative emotional states like anxiety, worry, moodiness, sadness, more frequently or intensely. The sources suggest this trait can predispose someone to depression.
Interesting. So if we compare the mood disorders based on what we've read, it seems like genetics, brain chemistry, life experiences, those are common threads.
Right.
But the real dividing line is the presence or absence of those manic or hypomanic episodes. That's what separates bipolar disorders from MDD in these sources.
That's a great summary of the core distinction presented in the material. Okay, so we've outlined the conditions themselves. Now let's move into how they're managed. The sources go into quite a bit of detail on treatment, especially using bipolar as an example for the phases of care.
Right. The sources break down care into different phases. Let's start with the acute phase. What's the focus there, especially if someone is experiencing severe mania?
In the acute phase, the sources state the absolute #1 priority is medical stabilization and ensuring safety, period. They list key nursing interventions for someone in a manic episode. Things like managing their hyperactivity, trying to prevent physical exhaustion or injury. Reducing environmental stimuli is crucial, creating a calm, quiet space, minimizing noise, crowds, bright lights.
Okay.
Ensuring the person gets adequate sleep and nutrition is also vital, as these often get completely disrupted during mania. And of course, very close monitoring for any signs of suicide risk or potential aggression towards themselves or others.
And medications.
Absolutely. Administering mood-stabilizing medications promptly is paramount in this phase to help bring those intense mood swings under control as quickly as possible.
Safety is clearly the main goal there, especially given the potential for impulsivity, maybe poor judgment, or even self-neglect during severe mania.
Exactly.
So once those acute symptoms are better managed, what happens in the maintenance phase, according to the sources?
Right, once things stabilize, the focus shifts to the maintenance phase. The goal here becomes more about long-term stability, preventing future episodes, relapse prevention, and improving the person's overall functioning in their daily life. The sources list interventions for this phase like psychoeducation.
Psychoeducation, teaching the patient and family about the illness.
Precisely. Helping them understand the condition, its symptoms, potential triggers, the importance of treatment. Medication adherence is a huge focus, helping the person stick with a prescribed regimen consistently. Therapies like CBT, cognitive behavioral therapy, come in here too to help manage thoughts and behaviors. Promoting strict sleep hygiene is mentioned, given how crucial regulated sleep is, especially for bipolar disorder, and helping the patient learn to recognize their own early warning signs of an episode starting.
So they can seek help sooner.
Exactly. This phase really emphasizes the chronic nature of these conditions, according to the sources, and the need for ongoing proactive management.
The sources also touch on the overall nursing process, applying to both bipolar and depression, right? What are some highlights there?
Yeah, they mention key things to look for during assessment, like observing for a flat affect, that lack of emotional expression, directly assessing for suicidal ideation, looking for vegetative signs.
Vegetative signs. Those are the physical ones.
Right, the physical symptoms like major changes in sleep patterns, appetite, or energy levels. Also assessing for feelings or expressions of hopelessness. Based on this assessment, the sources say appropriate nursing diagnoses are formulated to guide the care plan. For depression, this might be risk for suicide, chronic low self-esteem, or ineffective coping. For mania, it might be risk for injury or disturbed thought processes, connecting back to those core symptoms.
In the planning and interventions part, what do the sources emphasize?
They stress setting collaborative goals with the patient, making sure the goals are focused on managing specific symptoms and are actually achievable, realistic. Interventions mentioned include using therapeutic communication techniques, really listening, building trust, encouraging the person to express themselves, and promoting self-care activities, basic things like hygiene, nutrition, regular sleep patterns that can sometimes fall by the wayside during an episode. It's presented as very much a partnership approach.
Now, medications. Clearly a huge part of treatment for both conditions, and the sources seem to go into a lot of specifics here.
They really do, and they actually flag certain medication classes or details as particularly important, sometimes even using phrases like must know, suggesting clinical significance. For bipolar disorder, the sources identify mood stabilizers as the primary class of medication, and they specifically highlight lithium carbonate as the gold standard according to the material provided.
Lithium. And that comes with some really critical points to understand, doesn't it, based on the sources?
Absolutely crucial ones. The sources hammer home its narrow therapeutic range. That's the specific level of the drug needed in the bloodstream to be effective without becoming toxic.
Yeah, and that ranges.
They state it's 0.8 to 1.2 mql. Because this window between effective and toxic is so small, they emphasize that frequent blood draws are absolutely necessary to monitor the level carefully and prevent toxicity.
Okay. Any side effects mentioned for lithium?
Common ones listed in the sources include weight gain and the potential for developing hypothyroidism over time.
They also list other types of mood stabilizers, right? Anticonvulsants?
Yes, anticonvulsant medications are often used. Examples given in the sources are valproate, which you might know as Depakote, carbamazepine, Tegretol, and lamotrigine, lamictal.
Are there specific warnings or monitoring needs for those?
Yes. The sources note specific monitoring requirements for valproate and carbamazepine things, like regular checks of liver function and platelet counts, because these drugs can potentially affect those areas. For lamotrigine, there's a very specific warning highlighted about the risk of Stevens-Johnson syndrome. The sources describe this: it's a rare but extremely serious, potentially life-threatening skin rash. Needs immediate attention if it occurs.
Okay, serious potential side effects to watch for. What about the second-generation antipsychotics mentioned in the sources?
Right, medications like olanzapine, Zyprexa, risperidone, Risperdal, quetiapine, Seroquel, and lurasidone, Latuda, fall into this category. The sources note these are often used in the acute phase, particularly for managing severe mania or sometimes bipolar depression. They often act as a sort of bridge.
Well, bridge.
Yeah, like they help manage the acute symptoms quickly until the primary mood stabilizers, like lithium or the anticonvulsants, have had enough time to build up in the system and reach their full therapeutic effect, which can take a little while.
That makes sense. Going back to lithium for a second, the sources really seem to emphasize the danger of lithium toxicity. They even explain how it can happen just from fluid shifts because lithium acts like salt in the body.
Yes, this is a major warning point in the sources. They explain that because the kidneys handle lithium very similarly to how they handle sodium, salt, things like dehydration, or even just significant changes in salt intake, can cause lithium levels to build up dangerously. They outline distinct stages of toxicity, giving specific blood level ranges and the symptoms associated with each.
Okay, what are the early signs we should know about?
Early signs, typically seen when the level is between 1.5 and 2.0 μEQL, according to the sources, often include gastrointestinal upset, nausea, vomiting, diarrhea, also a fine tremor, usually in the hands, increased thirst and polyuria, that's frequent urination. Recognizing these early symptoms is vital because it signals the level is creeping up into the toxic range.
And if it progresses, what does severe toxicity look like?
Severe toxicity, which the sources associate with levels above 2.0 μEQL, involves much more dangerous symptoms. They list things like a coarse tremor, a much more pronounced shaking, confusion, ataxia, that's loss of coordination, unsteadiness, seizures can occur, stupor, which is like a state of near unconsciousness, hypotension or low blood pressure, coma,
Okay.
and potentially death.
Wow. Okay.
So recognizing those early signs and getting medical help immediately is absolutely critical to prevent it from progressing to that severe life-threatening stage.
Which means patient and family education about lithium is non-negotiable based on these sources. What are the essential teaching points they highlight?
They give a very clear practical list. First, maintain consistent salt and fluid intake. Avoid dehydration. That's key because, as we said, dehydration concentrates the lithium. Second, monitor closely for those signs of toxicity. Teach patients and their families what those early symptoms, nausea, tremor, thirst, look like. Third, stress the importance of getting regular lab tests, not just the lithium level itself, but also periodic checks of thyroid function and renal kidney function, as lithium can affect these organs over the long term.
Okay.
Fourth, take the medication exactly as prescribed. Critically, never double up on a dose if one is missed. Fifth, avoid certain other medications, specifically NSAIDs, that's common pain relievers like ibuprofen and diuretics, water pills, because these can potentially increase lithium levels in the blood.
And are there specific situations or conditions where the sources say lithium is absolutely contraindicated, should not be used?
Yes, they list several important contraindications. Pregnancy is a major one. Pre-existing significant renal disease, kidney problems. A condition called myasthenia gravis, MG, used in children under 12. Conditions that cause severe dehydration. And significant cardiovascular disease. These are presented as strong warnings in the sources.
Okay, that's a very thorough look at lithium based on the material. Let's shift to antidepressants now. These are the primary treatment for major depressive disorder, right? But the sources mentioned using them cautiously in bipolar disorder.
Exactly. Primary for MDD,
Yep.
but used with caution in bipolar because in some individuals, they can potentially trigger a switch into a manic or hypomanic episode. The sources actually put a lot of weight on this section about antidepressants. They explicitly state something like must know for exam in the material, which really highlights their perceived importance for clinical understanding.
Okay, so definitely key information. Where do they start?
They start with the SSRIs, selective serotonin reuptake inhibitors. Medications like fluoxetine, Prozac, and sertraline Zoloft are given as examples, and the sources identify these as the first-line treatment choice for depression.
First line. Okay. What about common side effects listed for SSRIs?
The sources mention things like agitation, insomnia. Interestingly, they also list hyponatremia, which is low sodium levels in the blood, something you might not immediately expect. And they describe something called discontinuation syndrome. This can happen if you stop taking an SSRI too abruptly. Symptoms listed are things like nausea, vomiting, headache, dizziness, basically feeling unwell, needs to be tapered off slowly.
Okay. What's next after SSRIs?
Next are the SNRIs, serotonin and norepinephrine reuptake inhibitors. Examples given are venlafaxine, Effexor, and duloxetine, Cymbalta. The sources note these are sometimes also used for treating certain types of chronic pain in addition to depression.
Side effects for SNRIs.
Listed side effects include nausea, dry mouth, sometimes insomnia, sometimes sedation. And the sources specifically point out that blood pressure should be monitored when someone is taking an SNRI.
Then there are the older ones, the TCAs, tricyclic antidepressants like amitriptyline.
Yes, amitriptyline and nortriptyline are examples given. But the sources attach some significant warnings to the PCAs. They're known for causing more prominent anticholinergic side effects.
Anticholinergic. That's the dry mouth, constipation.
Exactly. Dry mouth, constipation, blurred vision, difficulty urinating, sometimes confusion, especially in older adults. But the most crucial warning the sources give about TCAs is that they are lethal in overdose. This is a major safety concern compared to the newer agents like SSRIs. They also note photosensitivity, increased risk of sunburn as another potential side effect.
Lethal and overdose, that's a huge consideration. Okay, what about MAOIs? Monoamine oxidase inhibitors, like phenelzine. These seem even less common now.
Right. The sources position MAOIs like phenelzine, nardole, and tranylcypromine parnate pretty much as a last resort treatment option,
Why last resort?
primarily due to significant safety issues and dietary restrictions. The absolute biggest warning associated with MAOIs is the need to strictly avoid tyramine-containing foods.
Tyramine.
Yeah.
What kinds of foods are those, according to the sources?
They give examples like aged cheeses, cured meats like salami or pepperoni, fermented foods, sauerkraut, soy sauce, smoked or pickled fish, some types of beer, and red wine. Basically foods that have undergone aging, curing, or fermentation.
And what happens if someone eats those foods while on an MAOI?
The sources warn of the risk of a hypertensive crisis. That's a sudden, extremely dangerous spike in blood pressure, which can lead to stroke or other severe complications. It can be life-threatening. That's why they're generally reserved for cases where other antidepressants haven't worked.
Wow, that's a really serious food-drug interaction. Definitely explains the last resort label. Are there any other antidepressants mentioned?
Yes, there's a category the sources just label as other. This includes medications like bupropion, Wellbutrin, trazodone, and mirtazapine, Remeron. The sources make specific notes for these. Bupropion is noted to lower the seizure threshold, so it might increase the risk of seizures in people who are already susceptible. Trazodone is highlighted as causing significant sedation, so much so that it's often used off-label primarily as a sleep aid at lower doses. And mirtazapine is also noted as being quite sedating or drowsy and can sometimes cause vivid or abnormal dreams. For these reasons, both trazodone and mirtazapine are usually taken at bedtime.
Okay, that covers a lot of ground on the medications. It's clear from the sources that understanding these different classes, their side effects, and especially the major warnings is considered essential.
Definitely. The level of detail suggests this is core knowledge.
Beyond meds, the sources also talk about brain stimulation therapies, don't they?
They do. ECT, or electroconvulsive therapy, is mentioned. The sources describe it as a highly effective treatment, especially for severe or treatment-resistant conditions like severe mania or depression that hasn't responded to multiple medication trials, or when psychosis or catatonia are present.
So it's considered when other things haven't worked or the situation is very severe.
That seems to be the indication, yes, when rapid, definitive treatment is needed.
And what about RTMS?
That's repetitive transcranial magnetic stimulation. The sources describe it as a non-invasive technique that uses magnetic pulses to stimulate specific brain areas. It's listed as an option, particularly for treating depression, including bipolar depression.
How does it compare to ECT, according to the sources?
The sources suggest that while RTMS is generally considered less effective than ECT, it has the advantage of having fewer cognitive side effects, like memory issues, which can sometimes occur with ECT.
Okay. And finally, psychological therapies. The sources highlight these as a key part of managing both bipolar and depression.
Absolutely. They list several key approaches that are applicable across these mood disorders. CBT, cognitive behavioral therapy, is a major one they discuss.
How does CBT help, based on the description?
It focuses on helping patients identify and challenge distorted or negative thought patterns, and then develop more adaptive, effective coping skills and behaviors. So, for someone with depression, CBT might involve working on challenging pervasive thoughts of worthlessness or hopelessness. For someone with bipolar disorder, it might involve developing strategies to manage impulsivity during hypomania or to challenge grandiose thinking during mania.
Makes sense. And they also mention involving the family.
Yes, FFT, or family-focused therapy, is listed. This approach involves educating the entire family about the illness, working on improving communication patterns within the family, and developing collaborative problem-solving skills.
Why involve the family?
Well, the sources imply these illnesses significantly impact the whole family unit. Providing support and skills to the family can improve the patient's outcomes and reduce family stress.
Okay. What about IPS-RT? That's a mouthful.
Right, interpersonal and social rhythm therapy. The sources describe this therapy as specifically focused on helping patients stabilize their daily routines and biological rhythms, particularly their sleep-wake cycles. their circadian rhythms.
Linking back to sleep disruption being a risk factor or trigger.
Exactly. Especially in bipolar disorder, where maintaining regular sleep schedules and daily routines is considered very important for preventing mood episodes. IPSRT directly targets that.
Group therapy is also listed, I see.
Yes, for providing mutual support, reducing isolation, and offering a structured environment to learn coping skills from peers.
And general psychoeducation seems to be a theme throughout.
It really is. Empowering patients and their families with knowledge about early symptom recognition, the importance of medication adherence, developing relapse prevention plans. This is presented as fundamental to long-term management in the sources.
Are there any other treatments mentioned, maybe specifically for depression?
The sources briefly list a few others for depression. Lifestyle approaches like regular exercise, light therapy, especially for seasonal patterns of depression, and consistent sleep hygiene. They also mention integrative approaches, specifically listing St. John's wort. However, they immediately add a strong caution about the risk of serotonin syndrome if St. John's wort is combined with prescribed antidepressant medications, especially SSRIs or SNRIs.
Serotonin syndrome. What is that, briefly?
The sources don't define it in detail, but they highlight the risk. It's basically a potentially dangerous condition caused by having too much serotonin activity in the brain, which can happen when combining certain medications or supplements. Symptoms can range from mild, like shivering, diarrhea, to severe, high fever, seizures, muscle rigidity. It's a significant interaction risk they flag.
Okay, good to know that caution is there. Right, we've really charted the territory of mood disorders and their management based on these sources. Now, the material seems to take a significant turn towards substance use disorder, or SUD.
It does, and the sources make a very strong framing point right at the outset about SUD.
Which is?
That it should not be viewed simply as a bad habit, a lack of willpower, or a moral failing. Instead, the sources explicitly defined SUD as a chronic brain disease.
A chronic brain disease. That's a powerful reframing.
It really is. And it underpins how the rest of the information is presented. Before getting into the disease model specifics, though, they clarify some key terminology.
Okay, like what?
Definitions. Addiction is described as this compulsive chronic need. Could be physiological or psychological for a substance or even a behavior that continues despite obviously harmful consequences.
And intoxication, that's just being actively under the influence.
Pretty much. The sources define intoxication as a reversible, substance-specific syndrome, meaning the effects depend on the drug that results from recent ingestion. It causes noticeable changes in behavior, mood, perception, or physical functioning.
Okay. Tolerance.
Tolerance is needing more and more of the substance over time to get the same effect, or finding that the usual amount has a much weaker effect than it used to.
And withdrawal.
Withdrawal refers to the specific set of physiological and psychological symptoms that happen when someone who has become physically dependent on a substance suddenly stops using it, or significantly reduces their dose. These definitions help distinguish different facets of substance use and problems.
So, coming back to that core idea, SUD as a chronic disease, how do the sources elaborate on that model?
They describe it as a chronic, relapsing brain disease. Key characteristics listed are intense cravings for the substance, compulsive drug seeking and use, a loss of control over how much or how often one uses, and critically, continuing to use even when facing significant negative consequences, health problems, job loss, relationship issues, etc. And here's a really crucial point the sources make, one that directly challenges a lot of common stigma.
Yes.
They draw a parallel to other chronic medical illnesses like diabetes or asthma. Just like someone with diabetes might have periods where their blood sugar is poorly controlled, or someone with asthma might have flare-ups, the sources state that a relapse in SUD does not mean treatment has failed.
Okay, so relapse isn't failure.
No. According to this model presented in the sources, relapse is seen as a characteristic feature of the chronic illness itself. It signals a need to perhaps reevaluate and adjust the treatment plan, maybe intensify support, but it does not mean the person has failed or that recovery is impossible.
That's a really important shift in perspective, much less blaming.
Absolutely. It frames it medically.
Yeah.
And related to that chronic nature, the sources make another very strong statement. There is no known cure for addiction.
No cure.
That's the term they use. The implication seems to be that once the brain has undergone the changes associated with addiction, it may never fully revert to its pre-addiction state. They say something like, once addicted, the brain cannot function properly without the substance, according to the source material. This emphasizes the profound and likely long-lasting nature of the brain changes involved.
That's quite a statement about the permanence of those changes.
It is. It underscores the seriousness and the chronic management perspective. The sources also list common medical comorbidities often seen with SUDs, things like higher rates of cardiovascular disease, hepatitis C, HIV/AIDS, type 2 diabetes, alongside the psychiatric ones we've already touched on.
Right. And speaking of the brain changes, the sources dive a bit into the neurobiology, don't they? What's happening in the brain?
They focus heavily on the brain's reward pathway. Specifically, they mention the mesolimbic dopamine system.
Dopamine, the pleasure chemical.
Kind of, yeah. It's heavily involved in pleasure, motivation, reinforcement learning. The sources trace the key pathway involved, starting in the ventral tegmental area, VTA, projecting to the nucleus accumbens, and then influencing the prefrontal cortex. This is essentially the brain's natural circuit for experiencing pleasure and motivating us to repeat behaviors necessary for survival, like eating or sex. Substances of abuse, the sources explain, basically hijack this system
Hijack it how?
by causing an unnatural, massive surge of dopamine in the nucleus accumbens, much larger and faster than natural rewards. This intense flood reinforces the drug-taking behavior extremely powerfully, leading to cravings and compulsive use, overriding other priorities.
So it sort of short-circuits the brain's natural motivation system.
That's a good way to think about it. And while dopamine is central to that reward enforcement piece, the sources also mention other neurotransmitters get disrupted too.
Like which ones?
They mention GABA, which is the brain's main inhibitory or calming neurotransmitter, glutamate, which is the main excitatory one, crucial for learning and memory, and it plays a role in how environmental cues get linked to drug use and trigger cravings. And also serotonin and norepinephrine, which we know are involved in mood, arousal, and stress regulation. Substance use throws this whole complex neurochemical balance out of whack.
Okay. The sources also provide a quick overview of the DEA drug scheduling system. What's the purpose of that classification?
It's the system used in the United States to categorize drugs based on two main factors: their potential for abuse and whether they have a currently accepted medical use and treatment. It creates a hierarchy.
So what's at the top? Schedule 1.
Schedule 1 drugs, according to the sources, have the highest potential for abuse and, importantly, NO, currently accepted medical use in the U.S. Examples given are things like heroin, LSD, MDMA, ecstasy, and marijuana at the federal level, though state laws vary for cannabis.
High abuse, no medical use. Got it. What about Schedule 2?
Schedule 2 drugs also have a high potential for abuse, but they do have accepted medical uses, often with severe restrictions on prescribing and handling. Examples include many strong opioid pain relievers like morphine, oxycodone, fentanyl, as well as stimulant medications like amphetamines used for ADHD, and cocaine, rarely used medically.
Okay. High abuse potential, but some medical use. Then Schedule 3.
Schedule 3 drugs have a moderate to low potential for physical and psychological dependence compared to I and II. They have accepted medical uses. Examples include products containing less than 90 milligrams of codeine per dose, like Tylenol with codeine, ketamine, anabolic steroids.
It's Schedule 4.
Lower potential for abuse than Schedule 3. Accepted medical uses. This category includes many common anti-anxiety medications, the benzodiazepines like diazepam, Valium, lorazepam, Ativan, alprazolam, Xanax. Also sleep aids like Zolpidem, Ambien.
And finally, Schedule V.
Lowest potential for abuse relative to the other schedules, accepted medical uses. These generally consist of preparations containing limited quantities of certain narcotics, often for anti-cough or anti-diarrheal purposes, like cough syrups with small amounts of codeine. It just provides a framework for the legal and risk classification.
Right. And one last point in the section, the sources bring up co-occurring disorders again, sometimes called dual diagnosis.
Yes, reinforcing the point that SUDs very often occur alongside other mental health conditions. They list the common ones again: depression, anxiety disorders, PTSD, bipolar disorders, schizophrenia, ADHD, various personality disorders. It's the rule rather than the exception, really.
And they made an important point about how substance use can affect the other symptoms.
Yes, a really critical clinical point. Substance use can sometimes mask the symptoms of an underlying psychiatric disorder, making it harder to recognize. Or, conversely, it can worsen those symptoms. Someone might be using alcohol to cope with anxiety, for example, but the alcohol use itself can ultimately make the anxiety much worse over time and also complicate treatment. It highlights why assessing for and treating both conditions concurrently is often essential, but also very complex.
Definitely adds layers of difficulty. Okay, let's dig into some of the specific substances and the SUD management approaches outlined in the sources. They seem to provide a table or overview of major groups.
Yeah, they give examples. We can touch on a few key ones they detail. Let's start with alcohol.
Okay, alcohol use disorder. What do the sources highlight?
For intoxication, they list the familiar signs. Slurred speech, ataxia, that's the unsteady gait, poor coordination, impaired judgment, maybe aggression or sedation, depending on the person and amount. Withdrawal from alcohol is emphasized as potentially very dangerous. Symptoms range from tremors, anxiety, sweating, nausea, insomnia in milder cases, up to the risk of seizures and, critically, delirium tremens or DTs.
DTs, those are the really severe withdrawal symptoms.
Yes, DTs are a medical emergency involving severe confusion, disorientation, hallucinations, often visual or tactile, like feeling bugs crawling on the skin, agitation, fever, high blood pressure, rapid heart rate. It can be fatal if not managed properly.
Wow. And overdose risk with alcohol.
The main risk listed is respiratory depression, breathing slowing down or stopping, especially if combined with other sedating drugs. Coma is also possible.
How is alcohol withdrawal typically treated according to the sources?
The standard approach involves using benzodiazepines, like lorazepam or diazepam, to manage the withdrawal symptoms and, crucially, prevent seizures and DTs. The dose is usually based on the severity of withdrawal, often assessed using a standardized scale like the CIWA protocol mentioned in the sources. Thiamine, vitamin B1, is also essential to prevent Wernicke's encephalopathy, a type of brain damage common in chronic heavy drinking.
Okay. What about opioids? Heroin, fentanyl, prescription painkillers.
Opioid intoxication is described with characteristic symptoms. Euphoria initially, followed by drowsiness or nodding, and very specifically, miosis constricted or pinpoint pupils. Also slowed breathing. Opioid withdrawal, while intensely uncomfortable, is generally not considered life-threatening in the same way alcohol or benzo withdrawal can be. Symptoms are often described as severely flu-like: muscle aches, cramps, nausea, vomiting, diarrhea, chills, sweating, yawning, runny nose, rhinorrhea, goosebumps, just miserable.
But the overdose risk with opioid is extremely high, right?
Extremely high and extremely dangerous. The critical point the sources make about opioid overdose is the risk of respiratory arrest. The person stops breathing altogether. This is the primary cause of death in opioid overdoses.
And the treatment for that.
The sources emphasize the immediate administration of Narcan, the brand name for naloxone. Naloxone is an opioid antagonist. It rapidly reverses the effects of the opioid, knocks it off the receptors in the brain, and restores breathing. It's truly life-saving. For longer-term treatment of opioid use disorder, medications like methadone, buprenorphine, Suboxone, or naltrexone, Vivitrol are used.
Okay, let's talk about stimulants. Cocaine, methamphetamine, Adderall, even nicotine and caffeine fall in this category.
Broadly, yes, though the sources focus more on cocaine and meth. Stimulant intoxication symptoms include euphoria, heightened alertness, increased energy, talkativeness, reduced need for sleep or food. Physically, tachycardia, rapid heart rate, increased blood pressure, dilated pupils. The sources also list some specific signs like jaw swinging or teeth grinding, bruxism, hypervigilance, paranoia, potential for aggression, and with chronic use, significant weight loss, and sometimes chest pain or cardiac issues.
What about withdrawal from stimulants?
Stimulant withdrawal is often described as a crash. The sources note it typically peaks within about 48 hours. It's characterized mainly by psychological symptoms: profound fatigue, needing lots of sleep, increased appetite, intense depression, lack of pleasure, anhedonia, vivid, unpleasant dreams, sometimes agitation or anxiety. While very uncomfortable, it's not typically medically dangerous.
And overdose risk with stimulants.
Overdose can lead to dangerously high body temperature, hypothermia, seizures, stroke, heart attack, cardiac arrest, or severe agitation and psychosis.
How is stimulant withdrawal or overdose managed?
Treatment is largely supportive, according to the sources. For withdrawal, rest, and support. For overdose or severe agitation, benzodiazepines might be used to manage agitation or seizures, cooling measures of hyperthermic, close monitoring of cardiac status. The sources note that inpatient medical detox isn't usually required for stimulant withdrawal itself, unlike alcohol or benzos.
Okay, speaking of benzodiazepines, benzos, the anti-anxiety meds like Xanax, Valium, Ativan, what do the sources say about them?
Benzo intoxication symptoms are mainly sedation, drowsiness, confusion, impaired coordination, slowed thinking. Similar to alcohol in some ways. Now, benzo withdrawal, this is another one that sources flag as potentially very dangerous, even fatal. Symptoms can include severe anxiety, insomnia, tremors, sweating, increased heart rate and blood pressure, and critically, a high risk of seizures. Sometimes psychosis or delirium can occur. The sources stress death is a possible outcome of abrupt or unmanaged benzo withdrawal.
Fatal withdrawal, that's serious.
Extremely. That's why the sources strongly emphasize that benzodiazepine withdrawal typically requires inpatient medical management. The dose must be titrated down very slowly and carefully over weeks or even months, often by switching to a longer-acting benzo like diazepam and then gradually reducing it. Abrupt stopping is highly dangerous.
An overdose risk with benzos.
Overdoses, especially if taken alone, often causes profound sedation or coma, but usually not fatal respiratory depression unless combined with other sedatives like alcohol or opioids. If combined, the risk of respiratory arrest increases dramatically.
Is there an antidote for benzo overdose?
Yes, the sources mention flumazenil can be used in some cases to reverse the effects, but its use is complex and sometimes risky, especially if the person might also be dependent on benzos, as it can trigger withdrawal seizures or has taken other drugs. So supportive care and careful tapering for withdrawal are key. The sources also add that for treating the underlying anxiety long-term after getting off benzos, SSRIs, or maybe Buspar might be considered.
Got it. The sources also include cannabis. What do they highlight there?
They make an interesting point that cannabis products today are often much stronger in terms of THC content than they were, say, back in the 1990s. Intoxication effects depend a lot on the specific cannabinoids. THC is associated more with euphoria, altered perception, sometimes anxiety or paranoia, and slowed reaction time. CBD is generally associated with more calming effects. Cannabis withdrawal symptoms are listed as generally mild compared to other substances, primarily irritability, anxiety, insomnia, decreased appetite, restlessness, not considered medically dangerous.
Overdose risk.
The sources state that cannabis overdose is generally not considered life-threatening, although high doses, especially with edibles, can cause significant anxiety, panic, paranoia, or temporary psychosis in some individuals. Treatment is usually just supportive care reassurance.
Okay. What about hallucinogens, LSD, psilocybin, PCP, and inhalants like solvents, aerosols?
Hallucinogen intoxication is characterized by, well, hallucinations, altered sensory perception, changes in thought processes, sometimes paranoia or dissociation. Withdrawal from classic hallucinogens like LSD or psilocybin is noted as rare or minimal. Overdose risk with hallucinogens isn't typically physical fatality, but can involve severe panic, agitation, aggression, especially with drugs like PCP, or engaging in dangerous behavior due to altered perception. And the sources add a very serious potential long-term risk. Permanent brain damage is possible with some hallucinogens or heavy use. Treatment is primarily supportive, providing a safe, calm environment.
And inhalants.
Inhalant intoxication causes rapid effects like euphoria, dizziness, slurred speech, lack of coordination, excitability. Withdrawal is usually minimal. However, the sources highlight a critical immediate danger with inhalant overdose: cardiac arrhythmia. They use strong language, stating that inhaling certain volatile substances can kill you immediately due to sudden cardiac arrest, sudden sniffing death syndrome. This makes inhalant use incredibly risky. Other risks include suffocation, seizures, coma, and long-term organ damage. Treatment for overdose is supportive care, managing cardiac issues if they arise.
That immediate death risk is terrifying.
It really is. Okay, the sources also give some extra specific details about alcohol use disorder, AUD, perhaps because it's so prevalent.
Right. They define different types of problematic drinking.
Yes. They define binge drinking. For men, 5 or more standard drinks in about 2 hours. For women, 4 or more in about 2 hours. Heavy drinking. For men, consuming more than 14 drinks per week on average. For women, more than 7 drinks per week. And then alcohol use disorder, AUD itself, which is a clinical diagnosis based on a pattern of use causing significant distress or impairment according to specific criteria.
And they mentioned a critical time frame for alcohol withdrawal.
Yes, they noted withdrawal symptoms typically begin within 6 to 72 hours after the last drink. And importantly, the severity tends to peak around the 72-hour mark. They included a note like, if you can get past 72 hours, that is the peak, implying that's the period of highest risk for severe complications like seizures or DTs.
The sources also listed a pretty grim catalog of the damaging effects of chronic heavy alcohol use on the body, didn't they?
They did. A wide range of organ systems are affected. Effects on the brain include shrinkage, memory problems, and specifically Wernicke's encephalopathy, that brain damage linked to thiamine deficiency, causing confusion, coordination problems, and severe memory deficits, sometimes progressing to Korsakoff syndrome, which is more permanent. Liver damage is classic, potentially leading to fatty liver, hepatitis, and eventually cirrhosis, scarring. The GI tract can be affected, with risks like gastritis, ulcers, and pancreatitis. Cardiovascular problems include hypertension, high blood pressure, and cardiomyopathy, weakening of the heart muscle. Risk of fetal alcohol syndrome if used during pregnancy, increased risk of various cancers, plus significant psychiatric issues, worsening depression, anxiety, psychosis, and major social problems, job loss, relationship breakdown, legal issues. It's a systemic impact.
Looking at the list of nursing diagnoses for SUD in the courses really drives home that broader impact, beyond just the physical dependence.
Absolutely. For AUD specifically, they list diagnoses you might expect, like risk for injury due to intoxication or withdrawal, but also ineffective coping, risk for violence directed at self or others, and imbalanced nutrition. For SUD in general, they add diagnoses like powerlessness, denial, social isolation, and chronic low self-esteem. These really capture the deep psychological and social challenges that often accompany addiction, fitting with that chronic disease model.
So what about specific treatment approaches the sources outline just for AUD, beyond the general withdrawal management?
They list both medications, pharmacotherapy, and psychological therapies. On the medication front, there are a few options mentioned to help people maintain abstinence or reduce drinking. One is disulfiram, brand name Antabuse. This is what's called an aversive agent. If someone drinks any alcohol while taking it, the drug interferes with alcohol metabolism, causing a buildup of acetaldehyde, which leads to extremely unpleasant symptoms: intense nausea, vomiting, flushing, headache, heart palpitations. It basically makes drinking feel horrible, creating a strong deterrent.
So it relies on the person knowing they'll get sick if they drink.
Exactly. It requires motivation and adherence. Another medication listed is naltrexone, available as a daily pill, Revia, or a monthly injection, Vivitrol. Naltrexone works differently. The sources say it helps reduce alcohol cravings. And it blocks the euphoric or pleasurable effects of alcohol if someone does slip and drink. It works on that opioid receptor system involved in reward.
So it makes drinking less rewarding.
Right. Then there's a camprosate, brand name Camprol. This medication is thought to help restore the balance of certain neurotransmitter systems, especially glutamate, that get disrupted by chronic drinking, thereby reducing prolonged withdrawal symptoms like craving, anxiety, and insomnia, making abstinence easier to maintain. And crucially, the sources re-emphasize thiamine, vitamin B1, supplementation as essential, not just during detox, but often ongoing, specifically to prevent or treat Wernicke-Korsakoff syndrome.
Okay, those are the medications.
What do you got there?
What are the psychological therapies mentioned for AUD?
The sources list several key evidence-based approaches. CBT, cognitive behavioral therapy, helps people identify triggers for drinking, challenge thoughts that lead to drinking, and develop coping skills to manage cravings and high-risk situations. Motivational interviewing, MI, is also highlighted. This is a counseling style focused on helping people explore and resolve their own ambivalence or uncertainty about changing their drinking behavior. It's very client-centered, guiding them towards their own motivation to change. 12-step programs, like Alcoholics Anonymous, AA, are mentioned as a widely available peer support approach. And family therapy is also listed, recognizing the impact on and potential support from the family system.
The sources also seem to lay out a kind of continuum of care for SUD, showing different levels of treatment intensity someone might go through.
Yes, it shows recovery isn't usually a single event, but often a process involving different stages or levels of support. It typically starts with detoxification, that medically managed withdrawal phase we discussed, especially critical for alcohol and benzos. After detox, someone might move to rehabilitation. This could be inpatient residential rehab, living at a facility for typically 28 days or longer, receiving intensive therapy, education, and structure. Or it could be outpatient rehab, attending therapy sessions regularly while living at home.
Okay. What comes after inpatient or intensive outpatient?
There are step-down levels. Partial hospitalization programs, PHPs, or intensive outpatient programs, IUPs, are mentioned. These involve attending structured therapy for several hours a day, multiple days a week. The person typically lives at home, or perhaps in sober living. It's less intensive than inpatient, but more than standard outpatient. Then there's standard outpatient counseling, which might be weekly individual or group therapy sessions, providing ongoing support and education as someone reintegrates into their life. Sober living residences, or halfway houses, are described as transitional housing options. They provide a substance-free living environment with peer support, often requiring residents to attend meetings or be involved in treatment.
And relapse prevention.
Relapse prevention is presented as an ongoing, crucial part of long-term recovery, not just a specific program. It involves continuously using the coping skills learned in treatment, like managing cravings, avoiding triggers, maintaining engagement with support systems, like therapy, support groups, peer support, making positive lifestyle changes, and having a plan for how to handle slips or potential relapses early.
Mm-hmm.
The sources really frame recovery as this multi-step ongoing journey consistent with that chronic disease perspective.
Okay, a comprehensive look at SUD from the sources. Now, the final major section seems to shift to handling acute safety crises specifically, dealing with suicidal behavior and managing aggression or violence. Let's start with suicide and non-suicidal self-injury, NSSI.
Right. The sources begin by making some important definitional distinctions here. Suicidal ideation, SI, is defined simply as thinking about, considering, or planning suicide. A suicide attempt, SA, is described as a non-fatal, self-directed, potentially injurious behavior performed with the intent to die as a result of the behavior. The intent is key. Suicide itself is defined as death caused by self-directed injurious behavior with intent to die. And then there's non-suicidal self-injury, or NSSI. This is defined as deliberately harming oneself, like cutting, burning, hitting, but without any intent to die. The purpose might be to cope with intense emotional pain, to feel something other than numbness or self-punishment, but death is not the goal. Distinguishing intent is crucial for assessment and intervention.
Okay, understanding those distinctions is important. Why do people engage in these behaviors? What risk factors do the sources identify?
They list quite a few, falling into several categories. Psychiatric illnesses are a major risk factor. The sources explicitly mention depression, bipolar disorder, anxiety disorders, schizophrenia, and substance use disorders. This clearly links back to everything we've discussed earlier.
So having one of those conditions significantly increases risk.
Yes. Biological factors are also mentioned, such as potentially lower levels of serotonin in the brain and having a family history of suicide or suicide attempts. Cognitive and environmental factors include things like experiencing bullying, suffering a major loss, job, relationship, death of a loved one, history of trauma or abuse, having chronic physical pain or illness, and critically, the sources highlight access to lethal means.
Access to means like guns, pills.
Exactly. Having easy access to methods that could be used for suicide is identified as a significant risk factor. The implication is that reducing access like safe storage of firearms or limiting quantities of potentially lethal medications is an important prevention strategy.
Are there broader social or cultural factors mentioned?
Yes. The sources touch on things like the stigma surrounding mental illness and seeking help, which can prevent people from reaching out. Issues related to gender identity or sexual orientation, especially if facing discrimination or lack of support, and significant social stressors like major financial problems, legal troubles, or homelessness. It's presented as a complex interplay of factors.
How did the sources suggest assessing someone's immediate risk? What should you look for?
They suggest looking for clues, which can be verbal or behavioral. Behavioral clues might include a sudden, sometimes paradoxical, improvement in mood after being deeply depressed, which might indicate they've made a decision and feel relief. Giving away prized possessions, withdrawing from social contact, or increased substance use. Verbal clues can be overt, like I want to kill myself or I wish I were dead. Or they can be more covert, like I won't be a problem for you much longer, nothing matters anymore, or I just can't take it anymore. The sources stress taking all such statements seriously.
Isn't there a common belief, though, that asking someone directly if they're thinking about suicide might plant the idea in their head or make it worse?
That's a really important point, and it's one of the major myths the sources specifically debunk. Myth. Asking about suicide increases the risk. The sources state clearly that asking directly, caringly, and non-judgmentally about suicidal thoughts can actually reduce the risk. It opens the door for communication, shows you care, and allows the person to potentially share their pain and get help. It does not plant the idea.
That's incredibly important to know. What other myths do the sources address?
Another one, myth. People who are serious about suicide keep their intentions completely secret. F.C. Shea. The sources say most people who die by suicide have given some kind of clue beforehand, whether verbal or behavioral. This reinforces why paying attention to those warning signs and asking directly is so important.
What about the difference between males and females? Is there a myth there?
Yes. Myth. Males are more likely to attempt suicide. Faxi PT. The sources clarify that while females are more likely to attempt suicide, males are significantly more likely to die by suicide.
Why the difference?
The sources imply this is largely due to the methods typically chosen. Males tend to use more lethal methods, like firearms, resulting in a higher completion rate, whereas females may more often use methods with a lower immediate fatality rate, like overdose, leading to more attempts relative to completions.
Okay. The sources also describe something called a lethality assessment. What does that involve?
This is a way to gauge the immediacy and seriousness of someone's suicide risk once ideation is identified. It involves asking specifically about three key elements: the plan, the means, and the intent. Plan. Do they have a specific plan for how they would attempt suicide? The more detailed and specific the plan, the higher the risk. Means. Do they have access to the method they plan to use? If the means are readily available, the risk is higher. Intent. How determined are they to carry out the plan? Have they decided when they might do it? Strong intent indicates higher immediate risk. Assessing these helps determine the level of intervention needed.
And if someone is deemed high risk, what immediate safety measures do the sources mention?
For someone at high imminent risk, especially in a clinical setting, the sources list environmental safety interventions like removing any potentially dangerous objects from the person's vicinity. Sharp items, belts, cords, plastic bags, sometimes even ensuring they use plastic utensils instead of metal ones. Providing constant 1.1 observation where a staff member stays with the person at all times. Ensuring the environment itself is safe. Example, ligature-resistant fixtures.
Okay, shifting now to the other crisis behavior covered in the sources: anger, aggression, and violence. They seem to present these as points on a spectrum.
That's right. They define anger as the emotional response, feeling mad, irritated, resentful, often in response to a perceived threat or frustration. Aggression is the behavior that follows it. Could be verbal, yelling, threatening, or physical, hitting, pushing, intended to intimidate or harm. Violence is the most severe and the intentional use of physical force with a high likelihood of causing injury, harm, or death to another person. It's an escalation.
Where do the sources say violence is most commonly encountered in a hospital setting?
They list a few specific areas: emergency departments, EDs, psychiatric units, intensive care units, ICUs, and geriatric units.
Why those places specifically, do the sources say?
They don't explicitly spell out the reasons in the material we have, but you can infer possibilities. EDs are high stress, often involve people under the influence or in acute crisis. Psychiatric units obviously manage patients with conditions that can sometimes involve agitation or psychosis. ICUs deal with critically ill patients who might be delirious, scared, or in pain. Geriatric units may have patients with dementia or other cognitive impairments leading to confusion and agitation. These settings inherently have higher risk factors present.
And what risk factors for aggression or violence do the sources mention more broadly?
They cover several domains. Biological factors include things like a history of head injury or traumatic brain injury, TBI, potential genetic predispositions or imbalances in neurotransmitters like low serotonin or high dopamine being implicated sometimes. Psychological factors connect back to our earlier discussions, conditions like PTSD, bipolar disorder, especially during mania, schizophrenia, particularly with paranoia or command hallucinations, antisocial personality disorder, and importantly, substance use, especially intoxication or withdrawal from certain drugs like stimulants, alcohol, PCP. They also mention behavioral theory, suggesting aggression can be a learned response that gets reinforced if it achieves a desired outcome. And social learning theory, suggesting people can learn aggressive behaviors by observing others, family, peers, media. It's presented as multi-determined.
So understanding these potential underlying factors is important for anticipating and maybe preventing escalation. When faced with escalating anger or aggression, the sources outline a very clear hierarchy of interventions, right? Starting with the least restrictive.
Absolutely.
Yeah.
This is a core principle emphasized for safety and patient rights. The absolute first line of response, whenever possible, is verbal de-escalation. The goal is to use communication skills to calm the person down and resolve the situation without needing any physical intervention or coercion.
What are some of those key verbal de-escalation techniques the sources list?
They provide a pretty good list of practical techniques. First, maintain your own calmness and confidence. Your demeanor sets the tone. Use non-threatening body language. Keep your hands visible. Stand at an angle rather than face-to-face. Avoid crossing your arms or appearing confrontational. Speak clearly, simply, and respectfully. Avoid jargon or complex sentences. Maintain adequate personal space. The sources suggest at least 1 arm's length, maybe more. Invading personal space can feel threatening and escalate things. Offer choices and options whenever possible, even small ones. This gives the person a sense of control. Would you like to take a break in your room or sit here in the quiet area? Use active listening. Reflect back what you hear them saying. So it sounds like you're feeling really frustrated right now because
Validates their feelings.
the walk and talk technique is sometimes helpful. Walking alongside someone can feel less confrontational than sitting face to face. And try to reduce environmental stimuli. Move to a quieter place. Turn down TVs or radios. Perhaps ask other people to step away if their presence is agitating.
So the goal is to lower the tension using communication and environment management first.
Always the first goal.
But if verbal de-escalation isn't working or isn't possible and the risk of harm remains high, what's the next step according to the sources? Seclusion.
Seclusion is mentioned as a more restrictive intervention. It's defined as involuntarily confining a patient alone in a specially designated locked room from which they are physically prevented from leaving. The sources are clear about the indications. It should only be used if there is an imminent risk of harm. The person is in immediate danger to themselves or others. A&D, all less restrictive methods like verbal de-escalation or offering medication, have been tried and failed. It's not for punishment or convenience.
Are there strict rules around using seclusion?
Very strict requirements listed in the sources. A physician or licensed independent practitioner must provide an order, usually within 1 hour of the seclusion starting, requiring a face-to-face assessment. The patient must be monitored continuously, either visually or via audio-video. The seclusion room itself must meet safety standards, no dangerous items, safe fixtures. And importantly, a debriefing session involving the patient should occur after the seclusion ends to discuss what happened and why it was necessary.
Okay, and if seclusion isn't enough or isn't appropriate and the danger is still immediate and severe, then restraints are considered.
Yes, the sources are very clear. Restraints, whether physical holds by staff or mechanical devices like wrist ankle cuffs or vests that restrict movement, are the absolute last resort.
Last resort. And the indications.
Only when there is imminent severe danger to the patient or others, and all other less restrictive interventions, de-escalation, seclusion if applicable, medication, have failed or are inappropriate for the situation. They must be medically necessary to prevent serious harm, and critically, they must be time-limited.
The sources mention strict legal and clinical guidelines for restraint use.
Extremely strict guidelines are detailed. A provider, doctor, NP/PA, must conduct a face-to-face evaluation of the patient, usually within 1 hour of the restraints being applied. There are specific time limits for how long a restraint order can last before needing renewal and reassessment. The sources list typical limits. For adults, 18 and over, a maximum of 4 hours per order. For adolescents, ages 9-17, a maximum of 2 hours. And for children under 9, a maximum of 1 hour per order. These times emphasized restraints are for immediate crisis management, not long-term control.
And monitoring during restraints.
Constant monitoring is required, with very frequent checks documented typically every 15 minutes. These checks include assessing vital signs, checking circulation in the restrained limbs, assessing skin integrity under the restraints, offering range of motion exercises when safe, and assessing basic needs like hydration, nutrition, and toileting.
The sources also said restraints are never PRN, as needed.
Absolutely not. They cannot be ordered as needed. Each episode of restraint use requires a specific order based on a current assessment of imminent danger. It's not a standing order. And thorough documentation is mandatory, describing the specific behavior leading to restraint, detailing all the less restrictive interventions attempted first, the type of restraint used, the patient's response, all the monitoring checks, and the rationale for continuing or discontinuing. Accountability and safety are paramount.
They also mentioned chemical restraints briefly.
Yes, this term refers to using medication specifically to manage acute agitation or aggression when de-escalation fails and the person poses an immediate risk. It's used to help calm the patient quickly. Examples listed in the sources include antipsychotics like haloperidol, often given with benztropine or diphenhydramine to prevent side effects like stiffness or restlessness, known as EPS or extrapyramidal symptoms, or newer antipsychotics like olanzapine or ziprasidone, often available in fast-acting injectable forms. Benzodiazepines like lorazepam are also commonly used for acute agitation. The choice depends on the clinical situation and facility protocols.
So throughout all these potential crisis interventions, what are the key nursing responsibilities highlighted in the sources?
The overarching responsibilities emphasized are always prioritizing a patient's dignity, rights, and safety above all else, consistently attempting to use the least restrictive intervention appropriate for the situation. During any restrictive intervention like seclusion or restraint, nurses are responsible for diligent monitoring to prevent injury to patient or staff, checking for things like aspiration risk if the patient is heavily sedated, and being mindful of the potential for emotional trauma from the experience. And a really important responsibility highlighted is conducting a debrief after the crisis incident is over.
Debriefing. What does that involve?
It involves talking with the patient, once calm, and the staff involved, reviewing what happened leading up to the incident, discussing how staff responded, identifying what interventions seemed helpful or unhelpful, assessing the patient and staff for any injuries, and critically, determining what could potentially be done differently in the future to prevent similar escalations or manage them better. It's presented as a crucial learning and quality improvement process, focused on safety, patient rights, and improving care.
Wow. Okay. We have definitely taken a really deep dive today, navigating entirely through the lens of the sources you provided us. We journeyed through the nuances of bipolar disorder and major depression, the different types, the symptoms, the risks. We grappled with the source's strong framing of substance use disorder as a chronic brain disease, digging into the impacts of specific substances and the whole continuum of treatment. And we explored those really critical safety protocols, assessing suicide risk, debunking myths around asking about it, and understanding that careful step-by-step intervention hierarchy for managing aggression and violence, starting with de-escalation and moving only when absolutely necessary to seclusion or restraints, under very strict guidelines.
Yeah, we've covered a lot of ground. We've seen the intricate details the sources provide on diagnosis, the specific warnings and monitoring needed for medications like lithium or MAOIs, the risks associated with withdrawal from substances like alcohol and benzodiazepines. We've touched on that complex interplay of biological factors, environmental triggers, cognitive aspects, social influences, and really seen the paramount importance the sources place on safety protocols and using the least restrictive approaches in managing crises.
Understanding these concepts, being able to recognize some of the symptoms described, appreciating the real challenges of living with chronic conditions like SUD or bipolar disorder, and knowing about the safety measures and treatment approaches outlined in these sources, it feels incredibly vital, whether that's just for personal knowledge or for maybe supporting friends or family, or even just for understanding interactions you might have within healthcare systems. It really underscores the depth and complexity here.
It absolutely does. It shows just how much specific information and careful consideration is needed to approach these sensitive topics with the kind of care and understanding that the sources advocate for.
So as we wrap up this deep dive, maybe let's leave you, the listener, with a thought that really seems to emerge from the way these sources connect the dots. Consider just how deeply interconnected all these conditions are, based on the material we reviewed. We saw how psychiatric illnesses like depression and bipolar disorder are highlighted as significantly increasing the risk for developing substance use problems. We learned how substance use, in turn, can mask or actually worsen those underlying psychiatric symptoms, making diagnosis and treatment feel like putting together a really complex puzzle. And we saw how both psychiatric illness and substance use are identified as major contributors to the tragic risk of suicide. So the closing thought is this. What does this profound interconnectedness woven throughout the sources tell us about the absolute necessity and maybe the immense challenge of treating the whole person? Addressing all these interwoven facets together rather than trying to tackle just one diagnosis in isolation.
Yeah, it paints a picture of a complex web of challenges and risks, doesn't it? And it really underscores the need for those truly integrated, comprehensive approaches to care that are hinted at throughout the source material we explored today.
Definitely a lot to think about. Thank you for joining us for this deep dive into these critical topics.